Okay, here we go on our 2017 E&M. I'm in the professional edition. E&M actually starts on page 1. We do have some cheat pages here that I'm going to come back to after we kind of have an overview of this section. So, overarchingly, E&M, Evaluation and Management, is paying the physician for his time and expertise. So this is the section you're not going to find procedures, actions in here, cutting, popping, excising, repairing. None of that is in here. This section is only the physician's time and services. And this table of contents kind of gives you a little bit of a hint as to what you're going to see. So this first section is your new and established patients, which we'll go into that in a minute. Or actually, I think it starts here. Sorry, forget that. Here are your office visits, new and established, your hospital observation, your inpatient, your consultations, your emergency room, critical care, nursing facility, all of those are in here. Everything here. So again, when you read this table of contents, this is the physician's time and expertise, whether it's a face-to-face, a telephonic, a care plan, chronic care management, whatever it is, it's in this section. Your green pages, again, are your guidelines. You must know your guidelines in order to apply your codes correct. Now, how this course flows, we cover all of these organ systems and every part of the CPT in our basic coding course, and then we go right into our advanced. That uses the Next Step book, and with the advanced, we go back through all of these sections. So for this first part of the course, the basic part of the course, I just want you to get familiar. I want you to begin to understand the components of leveling, that kind of thing. And then we can kind of tweak it and become more advanced E&M people with our advanced course or in that next textbook. Okay, so here you go. Kind of gives you a blip of what E&M is. I kind of already helped you with that. What is a new and what is an established patient? New patient means they've never seen the doctor, or it is their doctor, but it's been over 3 years since they've been in. So that's key. That may be on your board. And established patients are obviously patients who routinely or within 3 years see that physician. The guidelines here kind of start going into the different parts of how you level a service. So you've got to have a chief complaint. There's different information about any kind of concurrent care or transfer of care. If there's any counseling, family histories, history of present illness kind of goes in with your chief complaint. You have to have that on every visit. There has to be a reason that you are having contact with the doctor, or insurance isn't going to pay. Then it actually starts some of the leveling information. Your textbook takes this much broader, but this is a good reference. I would recommend you not getting in the weeds here yet. Get into your textbook, start breaking it apart, and then come back, and I think you'll be able to read it with a higher level of comprehension. Different instructions on how to level. Again, I would read this once you've been through the chapter. Probably we will have several cheats that I will recommend you write into this green section once you understand what you're even writing in. Okay, so overarchingly, in order to code from the evaluation and management section, you must know 3 things, and I write them in my book, and I think about them every time I go to figure out what my E&M is going to be. One is the place of service. Where is the patient? Second, type of service. Inpatient, outpatient. Third, patient status. Are they a new patient or established patient? And all of this, I'm kind of following in your chapter 9 with this. I'm trying to see what page this might be on. I don't know. I was going to try to help you with that, but I don't know which page it's on. Okay, so your green headings kind of tell you the grouping of codes. So this is office and other outpatient services, new patients, established patients. Okay, so let's just talk about these for right now. This is an example of this would be you're going to your doctor's, never seen him before. You're establishing with a new doctor. You just moved to a new town. So you are a new patient, or you're moving back to someplace you've lived before. You used to see this doctor. It's been over 3 years, and now you're going to see him again. So this is your this is where the doctor is going to get their codes. If you look under every code or description, it tells you whether it's going to require 3 key components or 2 key components. Your key components are your history, your examination, and your medical decision making. Those 3, history, physical exam, medical decision making, will flow throughout this entire section. In order to level, you have to know what your history level is, what your physical exam level is, and what your medical decision making level is. And then you plug them into your code. So sorry. I thought I was getting better. Okay, so you have different levels within that history, different levels within the physical exam, different levels within the medical decision making. You have to take them one component at a time, determine that level, move on to the next, determine that level, and then determine the third level, and then put it all together to plug it into an actual code. Sounds very, very, very convoluted, and it is. It's a little mind-boggling at first. That's okay. There are people who have worked E&M levels for 10 years and still struggle some, or there are people that pick it right up. So let's just stick to the basics. So what have we learned so far? There's 3 things we need, 3 pieces of information we always need to pick out before we ever start figuring out where to go in E&M. Your place of service, type of service, and patient status. Within the E&M section, we have different locations. This first location is your office and other outpatient. You have within this a new patient and an established patient. If we look, our new patient, we have to meet 3 out of 3 components. Those 3 components are history, physical exam, and medical decision making. If we look at the established patient, we only have to meet 2 out of 3. Look at code 99212. You meet 2 out of 3 key components. The reason being is the physician knows that patient. They're not having to start from scratch. A new patient or someone that the physician hasn't seen before, you kind of have to start from scratch. An established patient, the doctor already knows. One of the first, one of the first notes I want you to put in here is code 99211. This is typically a nurse visit, and it tells you that the patient may not require the presence of the physician. This could be patient comes in for a blood pressure check, something like that. Patient comes in to have their blood sugar. Patient comes in for some type of shot and a blood pressure check, something like that. The shot you actually, or a vaccine or injection, would actually have an administration code. But if the nurse did something else, then they would get that as well. Maybe to have a wound looked at real fast. Something like that. That's a nurse's visit. Okay, so let's move on. Here we have our hospital observation services. The notes that you see written and the coding tips are imperative that you know and understand in order to use these codes correct. Our first conference call, we'll probably walk through this again. You guys will have lots of questions, I'm sure, and we can go over different guideline issues if you have questions. So here, the very first codes within observation are our discharge codes. There's only one. Now, this is a patient being admitted into observation and discharged from observation. So let's talk about the difference between admitted into the emergency room, admitted into observation, and admitted into inpatient. Because the admitted part is the same lingo they're going to use for all three of those. So if I'm admitted into the emergency department, that means something's happened and I need to go to the emergency room to have it checked out. I'm nonstop vomiting. I cut my leg. I broke my arm. Whatever those things are. That's admitted into the emergency department. They solve my problem, or at least get me fixed well enough or stable enough to go back home. Now, a patient admitted into observation typically kind of goes through the emergency department to get there. Not all the time, but most of the time. So let's say I'm a diabetic and I'm nonstop vomiting. I come into the emergency room. My blood sugars look pretty good, but gosh, I'm still just nonstop vomiting. So they're giving me all kinds of medicine, but they want to watch me for 8 hours or 12 hours just to see if the medicine works. I kind of stable out and then I can go back home. They don't really think I've met the criteria for inpatient admission, but I'm a little bit more than sitting in the ER for a couple of hours. So they, quote, admit me into observation. I may never leave my emergency room, little cubby room. I may stay there the whole time, or I could actually be physically moved up to a room on the floor, but I'm still in observation status. I've not been formally admitted into the hospital. It's all pending if they think I'm becoming stable or if they think I'm going to actually need an admit. So, kind of knowing the difference, here is our discharge. So this is when I finally get to leave observation. Here's my initial into observation. There's 3 codes, 99218, 99219, and 99220. If you look, you have to meet 3 out of 3 components on each of these, and you have your history, your exam, and your medical decision making. So see, now we're kind of becoming familiar with the components. So observation is by calendar day. So if I'm admitted on Monday into observation, they would use an 18, 19, or 20 code. And if I go home on Tuesday from observation, they would use a 17, 99217 code. Okay, still never formally admitted. You can actually be in observation up to 3 days, believe it or not. Sometimes longer, kind of gets weird. But so I'm initially put in, so these are your admit codes. You could write admit, whatever you want, is your 99218, 99219, and 99220. 1 calendar day. And then, so this is Monday, and then I go home Tuesday, which is 99217. So now we have our subsequent observation days. Let's say I was admitted in on Monday, 99218, 99219, 99220. I was there all day on Tuesday too, so that's a subsequent day. So you would code 99224, 225, or 226 for Tuesday. And then I went home on Wednesday, so that's 99217. You only use one set of codes per day. Your actual descriptions say per day. You cannot do an admit of 99218, 19 or 20 and a 99217 on the same day. You cannot do that. So your admit would be day 1, subsequent would be day 2 or day 3, whatever it is. And then your last day, the day they go home, the only code you would use is your discharge. Now we're going to hop over real fast to a different place. This is going to be on page 18. This all still has to do with observation, also inpatient, but since we're talking about observation, this is observation as well. Let's say on Monday morning, I was put into observation, and Monday night, I went home. If they are admitted into observation or inpatient and go home the same day, then you use codes 99234, 235, or 236. And it tells you includes admission and discharge on the same day. Okay, so that is observation in a nutshell. Now we're back on page 15, hospital inpatient services. If you turn the page, lots of good guideline kind of stuff. You have your initial, and you have your subsequent, and then we'll have our discharge in a minute. So initial, again, that's your admit, being put into the hospital, a formal admission into inpatient hospital. That's what this is. You have 99221, 99222, and 99223. Again, you must meet 3 out of 3 components: history, physical exam, medical decision making. We're not getting into how to determine a history level or a physical exam level at this point. We're just kind of learning about this book or this section. Okay, subsequent hospital, again, per day. So these are the codes 31, 32, or 33 that you use for not the admit day and not the discharge day, but all the days in between. How I like to think of these, just kind of going in, 2 out of 3 components are met here. And how I like to think of these is 99231. This means the patient's better and may actually get to go home tomorrow. So you're going to see that they've progressed well, they're responding well to medicine, they're up walking now, may discharge tomorrow. It's kind of what you might see. 99232, a subsequent hospital day, might be, the patient's been on IV antibiotics for 2 days, still running a fever. We're going to change the antibiotics and see if they respond better. They're stable. They're doing okay. They're just not progressing as well as we thought. So the patient's still on the road to recovery. They just have to kind of tweak some of the treatment. And then your 99233, this is patient coded, is now in ICU. Patient is rejecting the medicine. Patient has gotten significantly worse, something like that. So that's kind of how I think about them. And then it kind of helps me start formulating my idea of which code to use as I'm reading the note. Okay, so we had our admit into the hospital, 1 code per day, that's 99221, 222, 223. We have our subsequent days in the hospital, 231, 232, 233. This would be day 1, this could be day 2, and then discharged on day 3. This could be day 2, 3, 4, 5, 6, and discharged on 7. So just keep in mind, you can have as many in between days as they're in the hospital is how many subsequent that you have. Then we've already talked about these observation that's admitted and discharged the same day. So here's our discharge, hospital discharge. So they came in on Monday. We used our admit codes. They were there on Tuesday, so we used our subsequent. Now they're going home on Wednesday. So this is our discharge day. You have 2 codes to choose from. You do not, thank goodness, have to figure out any kind of history, physical exam, or medical decision making. This is wonderful. All you have to do is look at time. So if on your discharge summary or your discharge note that the doctor has written, if they didn't write how much time it took them to discharge, then they get 99238. If they wrote it took me 40 minutes to write the orders to discharge them, then they get 99239. It's determined by time. If there's no time, they get the lowest. All right, now we're moving into consultations. Okay, let's think back about the 3 pieces of information that we need to know. We need to review that because it's been like 5 minutes since we knew it and it's all new stuff. So let's go back here because we have it written. I know you guys wrote it down. You're supposed to. Here we go. Place of service, type of service, patient status. So here we're going in a new section. Consultation green is our new little section within this section. So we have office and other outpatient consultations. And then we have inpatient consultations. That's what we have under this consultations heading. You better make note that Medicare Part B doesn't cover any kind of consultations. So you would have to use your office visits. Okay, so we have office and other outpatient, that's our setting, and we have inpatient. So for our office consultations, again, we have lots of good kind of notes and tips to figure out how to code what we have. And then as you see, we have to meet 3 out of 3 components because in a consultation, you are brand new to that doctor. Okay, have to meet 3 out of 3. Again, you have your history, your exam, and your medical decision making. And then we have inpatient consultations. New or established, it doesn't matter. You meet 3 out of 3 components. Okay, so outpatient, inpatient, consultations. Medicare doesn't pay for them. Now we go into our emergency room. See, we're green again. Emergency room services. New or established, it doesn't matter. If you go to the emergency room every single night, you're still considered a new patient there. It isn't going to matter that the people know you. So you have 5 levels, 99281, 82, 83, 84, 85. Typically the last number, pretty much this whole thing, the last number tells you what the level is. So if a physician said, yeah, I saw the patient in the emergency room, it was a level 3, then it would be 99283 that physician is referencing. Now, you can't really take them at their word, so you have to go look at the documentation and tally up and make sure that they have enough documentation to support that level, but that's what they're talking about. Okay, other emergency services, 99288. This could be maybe, very sorry. Maybe the physician is on a hand radio or on a 2-way radio talking to the EMS, the ambulance coming in, directing the code, you know, for that patient or something. So that could be what that's used for. You don't necessarily see it a lot unless you have a high trauma emergency room that you work for. Okay, so that's emergency department. Moving into critical care services. Lots of notes on critical care. I would get familiar with the codes and then read them. Let's talk about the codes first, and then we're going to pull out some very critical information in how to use these codes and what's included with these codes when you go to use them. So anything under 29 minutes and less would not be critical care. Even if they provided those services, it's just going to be an E&M, like emergency room level 5. You have to have documentation that the doctor spent 30 minutes or more with the patient. I don't worry so much about these actual descriptions here. I look totally at this table. So if my documentation says I, as the physician, spent 70 minutes with this patient in critical care time, stabilizing them, coding them, whatever it is, I spent that time, 70 minutes in critical care with that patient, then I would take that 70 minutes, I would come in here and I would plug it in. 30 to 74 minutes is 99291. And that's what I would code, and I'm good, I'm done. So let's say that you have documentation that the physician spent 125 minutes with the patient in critical care time. I would come in here, plug in my 125. It falls in the 105 to 134 minutes. So I would code 99291 and 99292 times 2. Okay, these are all based on time. I do not ever do a times 1. Anything times 1 or anything times itself is itself. This is just kind of used as an example. You would never do a times 1. You do times 2 or times 10 or times 5 or whatever it is, but you don't do a times 1. Okay, so that's how you plug in your time. Now, critical care, if you read the guidelines, critical care time can be provided in any setting. Let me say that again. Critical care time can be provided in any setting. It could be in a lobby. It could be in a physician's office. It could be in the emergency room. It could be in the operating room. It could be on the sidewalk in front of the hospital. It could be, critical care can be at any location. It doesn't have to be ICU or emergency room, something like that. So keep that in mind. Now, if you look at the bottom of page 24 down here, it starts telling you, this kind of tells you a little bit about how to divide it up by time, talks a little bit about pediatric, that kind of stuff. We actually have an inpatient critical care stuff for babies and peds. So this kind of is helping you, telling you where to go for stuff. But if you look down here, the last paragraph, for reporting by professionals, the following services are included. Please listen. Are included in the critical care when performed during the critical period by the physician. Okay, so let me tell you that again. Within these codes, there are actually services bundled, services provided. Down here, it's telling you what they are. For reporting, the following services are included in critical care when performed. So that's interpretation of cardiac output measures, and then they give you some CPT codes to kind of help you out. Any chest x-rays that are done, bundled in. Any pulse oximetry, this is a pulse ox, the little thing they put that glows red that they put on your finger, that's what this is. Any blood gases, that's where they tap in here, right here in your wrist and get your blood gases, very painful. ECGs, used to be called EKGs, I still call them EKGs because I'm old. Blood pressures, hematologic data, gastric intubation, that's if they had to drop a tube to pump the stomach. Used to be called pumping the stomach. Now it's gastric intubation. Temporary transcutaneous pacing. This is an external pacemaker. Maybe they're having huge cardiac arrhythmias. Ventilatory management. This is they already are intubated and now we're managing that ventilator or respirator. Vascular access procedures, and then it gives you some. So if they had to, the physician had to place a central line, something like that, these are all included. 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 I know I sound funny now, but you guys will be glad I said that. Then it says any services performed that are not included in this list, you can report separately. So anything not a part of this, you can report separately. So be aware that within these critical care codes, you have stuff bundled. We'll go over this again. Half of you won't catch what I've just said, and we'll have to say it over and over, and some of you still probably won't. But really, really start at the beginning, taking everything that I'm saying to heart. I promise I don't just talk. So, critical care, plug in your time. Anything less than 30 minutes does not get critical care. Another part of critical care, say you have, because these are per day codes, so you can tally up the time. Say the physician said he spent 30 minutes this morning stabilizing the patient. Then he had to go back at 2 this afternoon, spend another 30 minutes stabilizing the patient. And then now tonight he spent 2 more hours stabilizing the patient. That's 3 hours total. So 3 times 60 minutes in an hour is 180 minutes. We can add all of that up for our per day critical care code. So then we just plug in 180 minutes, and then it'd be 99291, 99292 times 4. All right, I've probably hit that crazier than anything. Nursing facilities, these are your SNF units, used to be called skilled nursing. Could be within an actual nursing home like what we're used to, or could be a different floor on a hospital. That's called a SNF unit. These are intermediate care facilities and long-term care facilities. Just kind of gives you a little bit of information about them. You have your initial admitting. There are physiatrist or rehab specialist groups, and these are the codes that they use, and they go in and say a patient broke their hip. So they're an inpatient to fix the hip, and then they have to go to, quote, rehab for 3 weeks to get the intensive physical therapy and that kind of stuff. These are the admit and subsequent codes that you would use to pay the rehab specialist for that time in that skilled nursing unit. Again, we're meeting 3 out of 3 components for an initial and 2 out of 3 for our subsequent. Then we have our discharge from a nursing facility, still based on time, 30 minutes. And then other nursing facility, this could be like an annual recertification, something like that, to stay in there. Okay, the next few pages, we're not going to get quite as in depth. They're not as used codes. I just want you to be aware of them. So domiciliary, rest home, or custodial care. These could be like your group homes, that kind of thing. These could be a nursing home where they're just living. You know, they're not necessary that's where they have to go because they don't have a home anymore or can't stay at home alone anymore. That's what these are, whether they're new patient or established new patients being admitted in or being seen. No, that's not true because they're already admitted. Maybe they have a new doctor and the doctor's coming to their location to see them. So that would be a new patient to the physician. And then you're established. If you see under history, it's added interval history. Same thing with the SNF unit, it added the interval history. And what that interval history means is, okay, I saw you a month ago or I saw you last week. What's happened since then? I know everything before that, but now what's happened in the interval since the last time I saw you? So that's all that means. different specific care plan oversight in those nursing homes, that kind of thing. Home services, this is if the physician makes house calls. I do know of a couple of docs who actually do go into the home. They are awesome docs for doing that. New patient or established. A lot of docs don't want to take their time to do it. It's too bad because there are a lot of shut-ins that could really benefit. Anyway, okay, soapbox off. Prolonged services. If you can see, we have two different sections under prolonged services. One is with direct patient contact and one is without direct patient contact. So underline those so you know the difference. Again, this is based on time. So prolonged service, direct patient contact. Patient came in the doctor's office for a diabetic check. The physician spent 30 minutes with them talking about their diabetes and had to spend another 30 minutes talking to them about how to get it compliant because they're refusing their meds or they're not doing, you know, whatever. So he ends up spending a total of an hour or an hour and 15 minutes with this patient just in the office, but it's direct. He's counseling them or he's listening to them, whatever it is. I am very, very sorry. I can't control that. I wish I could. And I can't put off the videos because you guys need them. I've put them off for 2 weeks trying to get better. At least I'm talking now. Okay, so these prolonged services can be billed in addition to the evaluation and management office visit. They just have to meet the time factor. There needs to be very, very clear documentation with or supporting these extra codes. Can't just be, yeah, I spent an hour and 15 minutes talking about diabetes. Needs to be, I spent, 25 minutes in a regular conversation regarding her diabetic management. Patient had lots of questions regarding changing meds or changing how they do their finger sticks, and I spent another 40 minutes going through step by step how to accurately manage on a daily basis, whatever it is. But it has to be clear cut that, yep, here's this chunk of time and here's another chunk of time. Prolonged clinical staff. This is very specific to different locations or very complex cases that there's a team of people that could be helping in their care. Standby services. The only time that you can code for a standby service is if a physician has been specifically asked to, hey, can you come and stand by? I'm just not sure if I'm going to need your services or not, but in case I do, I want you right there. Example, patients in surgery, they don't know whether they're going to be able to keep their gallbladder or not. And the surgeon that's in there doesn't do gallbladders. So he wants a surgeon on hand who can step right in to take the gallbladder out. That's kind of a crappy example, but you kind of see what I'm talking about. Or cardiologist is in seeing the patient in ICU and is anticipating that potentially this patient is going to need intubated or some kind of respiratory intervention. So he wants the patient's pulmonologist right there on standby. So if he needs to pull him in, he can pull him in. That kind of thing. When the doctor is standby, they cannot be doing anything else but standing by. They can't be looking at another patient. You cannot be doing anything other than twiddling your thumbs. The examples here, I think sometimes it's like a C-section. OBGYN anticipates there may be some trouble with a vag delivery and they may have to convert to C-section, and maybe that doc doesn't do C-sections or something like that. So that could also be the case. Case management services. This is another green area. Case management. We have, and we're not going to get into depth about any of these. Just it's more for you to know that they're here and be familiar with them than anything. Anticoagulant management. This is patients taking Coumadin, warfarin, and they have to come in every week or every month for an INR or a blood test, INR. This is what could be billed for that. Medical team conferences. This is if you have a medical team that helps deliver the patient's care. This is them getting paid for their time together. Again, this is with the patient. Direct face-to-face contact with the patient. This is without direct face-to-face with the patient. So make sure you're underlining those. And I do not have them underlined. Shame, shame. I should have. I never see these codes. Care plan oversight. This is if a patient has a care plan. This is supervision, potentially home health, hospice. They're kind of divided. This is a home health. This is a hospice. This is a nursing facility patient. So they're different locations for different settings. Preventive medicine. This is a whole nother section. You're going to have a new patient. You're going to have an established patient. This is for the patient going in for their, quote, yearly check. Could be female for her PAP. Could be male, any sex, male or female, going in just for that yearly, hey, how you doing? Oh, you're doing great. That kind of thing. It could be a kid. Kids go into the doctors all the time, up to about 14 or 15 years of age, and then it slows down. So these could be all of those well baby checks, preventive childhood checks, that kind of thing. Divided by new patient or established patient, and then divided by age. And that's it. You don't have to count anything up for this either. It's a wonderful section. Yay! Okay, now we get into some counseling and risk reduction. This could be counseling for quitting smoking. This could be weight counseling. Could be in a group setting, could be individual. Okay, so this is helping to reduce risk factors that are affecting the patient's health. Sorry, I got sun coming in my window. I'll try to cover that. Well, but then, okay. Telephone, non-face-to-face, these are telephonic, and email, online stuff. Interprofessional telephone and internet consultations. Again, these are very, very, very specific, and you just don't see them that much. Special evaluation and management services. These, what falls under here is your insurance mandated services or your work related. So say you want basic life insurance and they say, well, you've got to have an exam. So this is where the doctor would get their E&M from, and then you would use 32, sorry, they added 33. You would use 32 modifier for a mandated service. So in order for you to get your life insurance, you had to have a examination. And so that 32 modifier flags it that, hey, the patient doesn't have to pay for this. The insurance company is what's asking for it. So then the insurance company picks up the bill. Work related. Now let's get into some newborn. We've got delivery room, attendance and resuscitation. So this is attendance in the delivery room if it's been requested, and initial stabilization of newborn. Then we have delivery room resuscitation. That's if the baby's born and has to be resuscitated. Stabilization of the patient, if it's done by a physician, could be sucking the lungs, maybe bagging it for, you know, a few minutes, a few seconds or something. This is when this is the stabilization, could be done by your NICU people or even other L&D people. But this is the initial stabilization, getting the fluid out of the lungs. All babies have it, especially C-section babies. and just kind of getting them all pink and crying. Your 6-5 is actual baby's really sick, was born really sick and needs some resuscitation. Your 99460, these here is just your routine initial hospital or birthing center newborn assessment of the baby. Now we get into some critical care of babies, peds and babies. This is specific pediatric critical care patient transport. This is very specific to transporting from one hospital to another, that type of thing, 24 months or younger. And then this next section, inpatient neonatal pediatric critical care. So our other critical care was for 29 days and over. This is for 28 days and younger, and it tells you. And your other critical care, remember we had, wait, let me get there. It did in all of that, right here on page 24, it did go into, remember I told you if the patient is this age, go here, if they're this age, go there, that kind of thing. This is where you can get some of that. So here is for our neonatal and pediatric. Here are our codes per day. I would underline if they're neonatal. Neonatal is 28 days or younger. So 6-8 and 6-9 are neonatal. I would underline those. 7-1, 7-2, 7-5, and 7-6 are all pediatric. So underline that. Pediatric is 29 days to 24 months. Okay, so with these codes comes a whole lot of guidelines. Just like our other critical care codes, there are procedures that are bundled into these codes if they're performed. So let's start here first. I'm on the second column, page 44. Second column starts with any services. Any services performed that are not included in these listings may be reported separately. So all of this list here is bundled in. All of this list is bundled in. And then it says any services performed which are not listed above may be reported separately. So if you are breaking your scenario apart and they have a peripheral catheterization, they did an umbilical cath, they intubated them, they did a lumbar puncture, all of those are bundled in. So don't code them extra. That would be considered unbundling and a huge no-no. Now, it does say down here, let's keep in, okay, let's talk about something real fast. So before we go to understand this next part. These codes are for an admitted into the hospital newborn. So that means they have been birthed and they have been formally admitted into the hospital. You will have, you're coding from their existing record that says they were admitted at 12 and at 12:10 they were intubated, whatever that is. You would know that the procedures happened after the admit time and date. Now, if a baby is born sick, they could actually be receiving emergency resuscitation procedures before they're formally admitted, and they're probably still in the delivery room. They've not been moved to the NICU. They've not been moved to ICU. They've not been formally admitted. Okay, so kind of get your head around that. So this next part at the bottom, and this is in green writing, the bottom of page 44, it says other procedures performed as a necessary part of resuscitation. And then it gives you an example. When performed as part of the pre-admission delivery room care. So if they are a pre-admit, they have not been formally, just because they come out of the woman's body doesn't mean they've been formally admitted yet. So if there is resuscitation that takes place before you have documented admittance into the hospital, then it falls under this pre-admit, and you can code for the services. These would then not be bundled in. Okay, that's about clear as mud. So we can talk about that more too. Okay, moving on. We have initial and continuing intensive care services. You can just kind of watch that. They're for very distinct, remember this is again still babies, very distinct reasons. And you can read those: low birth weight, that kind of thing. Then we have case management services. Case management is green, so we're out of babies and out of peds. This is for anybody. We have chronic care management services. I have a note written here because your chronic care management services are kind of like a monthly service, and they can actually be done not face-to-face. There could be a designated care coordinator that does all of those, and then the doctor just signs off on it. Okay, transitional care management services. We're almost done with this section, believe it or not. Okay, these are transition care, maybe coming inpatient to outpatient, transitioning from inpatient to rehab, whatever that kind of thing is. That's where this would be used. We have advanced care planning. This is doing your directives, your advanced directives. And then every section ends with their unlisted codes. All unlisted codes end in 99. If you have to use an unlisted code, which I've used one in 15 years, if you have to use one, then you have to have a special report to go with it. And I know that because, let me show you. Somewhere in my green pages. Where's my green pages? Just a minute. Special report on page 8. An unlisted service or one that is unusual has to have a special report go with it, written by the physician. Anything I tell you, I can generally always find the backup guideline to prove it. Okay, so that is what is in this evaluation and management section in a nutshell. Now, we kind of have an overview of what's in here. So that's good and fine. So when we have to go find a certain code, say we need to go, we're looking at an emergency room. So we know that there's an emergency room section. So we're just going to go to it and find our code. Now, the key to finding the correct code is knowing your levels. So these little cheat pages, and I'm posting this form that I'm pulling up right now, I'm posting this. You may want to take print 30 of them. This is your history. This is your examination. And this is your medical decision making. All lumped onto one page. Remember, you have to determine your history. Then you determine your physical exam. Then you determine your medical decision making, and then put them all together for your excuse me, for your actual level. I am so sorry. Okay, so what these pages are the different sections within E&M, kind of divided up into concise areas of for the level what you need. So for, let's pick level 99201 right up here in the corner. For this level, you need a problem-focused history, a straightforward medical decision making. You need your problem to be self-limited or minor. And then it kind of gives you maybe, good Lord, kind of gives you maybe what you might see if there was those additional contributing factors. which is counseling, coordination of care, or face-to-face time, which we generally do not like using. But then here it tells you for this level for this level of service, you typically spend 10 minutes. For your 99202, typically 20 minutes. For your 99203, typically 30 minutes. And you can find all of this underneath your actual codes. So let's go to 99201. Here it gives the problem focused and straightforward. Down here it tells you typically spends 10 minutes. And you have to have all three components. So then you would look at your note and just take each of these one at a time. That's why I'm saying you may want to print these off. And then you can have one for each scenario or example that you go through. So let's break each of these apart. Let's look at the history, just the history. That's all we're looking at. Remember when I said you always have to have a chief complaint or a history of present illness? Here it is. And there are different pieces of information that you can pull out to then get you your history of present illness level. Down here, you see your history of present illness, review of systems, and past families social history. I hope I don't have to stop this video. Yikes. Okay, so for the history of present illness for a level 1, you need 1 to 3 pieces of information in this section. For level 2, you need 1 to 3 pieces of information in the HPI. For level 3, you need extended 4 pieces. And then for level 4, extended 4 pieces. So let's say the patient has a cough that's lasted for 3 days. It's worse when she lays down and she takes cough syrup. So we kind of have location. Cough is coming from somewhere upper respiratory. Thank you very much. So that's one piece of information. Duration, it's been happening for 2 weeks for me. Timing, when it occurs, or the context to which it occurs. It's worse when the patient lays down. Modifying factors, what makes it better or worse? So better, your cough syrup. So there are 4 pieces of information for your HPI. So you actually have a high level of HPI right now. Then you pull out of your review of systems, you just tally it up, you just count it up and just check it. For review of systems down here, for a problem focused, you don't need any. For a level 2, you need a problem pertinent, so maybe looking at the lungs, or the patient says something about the lungs, respiratory. This review of systems is not the doctor's exam. This is subjective, coming either from the nurse or what the patient is saying. It's all subjective. Physical exam is what is objective from the doctor. For a level 3 review of systems, extended 2 to 9. So 2 up to 9 of these. And then for a complete review of systems is 10 plus. Then the last part of history is your past family social history. If you look down here, you don't even need any past family social history until a level 3. Then you only need 1, and then for a level 4, you need 2 or 3. So let's get some examples. Past illnesses, med list, something like that. Patient's married, patient smokes, patient's not allergic to any medicine. Patient lives alone. All of those kinds of things are considered past family social history. So you kind of tally that up, and then you go, say you have a level 4, a level 3, and a level 2. Always go with your lowest level for the history. So your level here would be a 2. You go with the lowest. If you have 4, 4, 4, you go with a 4. You got 4, 3, 3, go with a 3. You got 2, 1, 1, you go with a 1, whatever the lowest is. Physical exam. You have your constitutional, which is every chart has a set of vitals on them, or has weight, or has something like that. One or all of these counts as 1. One or all of these count as 1. Then you have a body areas, and you have an organ system. Your body area is just that. It's talking about your abdomen is round or your abdomen is hard. That's a body area. It is not objectively assessing the organs within the abdomen. So the organs within the abdomen would fall under gastrointestinal, which is normal active bowel sounds times 4. Now we know that the physician has actually listened and assessed the organs within that body area. So that's the difference between an organ system and a body area. Now, for your level 1, you've got to know the difference between your body areas and your organ systems. And then for a problem-focused physical exam, you just need 1, either body area or organ system, doesn't matter. For an expanded problem, you need 2 to 7 areas or organs. For a level 3, this is a limited, so limited would be abdomen round, eyes or pupils equal, heart stable, respiratory clear, just one word little answers. That's a limited. They've mentioned them, but it's very limited information that you have. Your level 3, same thing, 2 to 7, either body areas or organ systems, but it's extended information. So now your cardiac says regular rate and rhythm, no murmurs noted. Your respiratory now says clear to auscultations, no wheezes, no rhonchi, or says, something in the bottom part of the left lung, or, something like that. Very, very detailed. Still body areas and organ systems. Your level 4 is the only section that requires only organ systems. So for your comprehensive exams, you can only get the information out of assessing the actual organ system, and you need at least 8. Okay, so there again, you're gonna, and this one, there really isn't any tallying like there is here, go with the lowest or whatever. It just is what it is. If you have 4 body areas and 4 organ systems, it can't be comprehensive, because comprehensive is organ only. So then it's probably going to be between level 2 and 3, and then determine how detailed. If the physician gave extremely limited information, then it's going to be a level 2. If he was very detailed in his information about those body areas or organ systems, then it's a level 3. Okay, then you plug that in. Medical decision making. Your medical decision making has 3 areas. This one actually is pretty easy. The physical exam and the medical decision making are the easiest to me. The history gets so convoluted and it's crazy. So medical decision making, the first section is number of diagnoses or management options. So is there only 1 diagnosis? Are there 5 diagnoses? So determine that. If there's 1 diagnosis, are they doing 4 different things for it? If so, then it's multiple, because it's 1 diagnosis, but there's a whole lot of management options available. Amount of data or complexity of data. Did they say they reviewed the old chart? Did they have a lot of labs to look at? Is there an x-ray for them to look at? That's what you plug in here. And then risk of complication. This risk is if the patient walks out of this visit or out of the hospital and is non-compliant, doesn't do anything the doctor said, what's the risk of dying? If the patient has pneumonia and they don't take their antibiotics, that's pretty high risk. If the patient's diabetic and refuses to take their insulin, yeah, it's pretty high risk. If the patient has a left ear infection and doesn't want to take the antibiotics, not much risk there. They may go deaf, they may hurt, but they're probably not going to die from it. Most likely. I mean, there are outsider, complications in everything, but just, on the surface, what's the risk? Now, whereas in history, we took the lowest level, in medical decision making, take the higher level because this is the actual expertise of the physician. You can kind of plug it in here like we have the other areas, so you kind of know how to plug it in based on the 3 areas here. So let's say you had level 3, level 2, level 2. You're going to go with a level 3 for all of the medical decision making. Say you had 1, 1, 3, go with a 3. Okay? So your medical decision making, you're always going to defer to a higher, because this is the actual expertise of the physician. For history, you're always going to defer to the lower. Okay, so that's in a nutshell how and I would really recommend you using this E&M audit form. I think it's really going to help you. And that is how you determine your levels of service. So then, knowing that, these little cheat sheets here, I'll get to them in a minute. These little cheat sheets here will make a whole lot more sense now. And it just kind of condenses all the information that's written in the rest of the section, kind of condenses it here. So I don't know if you want to make notes here, if you want to put some cheats. We may even want to talk about what different cheats. Now we come back to these green guidelines. And now, since we've talked about stuff, we kind of understand how to plug in this information. Now we know what review of systems is. Now we know what a nature presenting problem is and a social history. Now we can kind of start to figure out how to determine the extent of history, how to determine the extent of exam, now that we've walked through that audit form and medical decision making. They do have this table for your medical decision making. I have had students that have copied this little history and exam. You already have it for medical decision making, but I've had them put it in before because they just got used to this layout. So do whatever you think you need to do. But I think this will get us a good start on E&M, most likely. Oh, and then your book also, to kind of break apart, like this is extensive history. Kind of breaks it apart, different questions that you ask to help determine these components of history of present illness are kind of broken down here in your chapter. So it kind of gives you some examples. So if it were me just starting to learn this stuff, I would probably have to make some little cheat cards of examples of duration, examples of location, examples of severity, that kind of thing. Maybe even have a cheat sheet, have a lot of blank ones, but then have one master that had examples of location and different, whatever you need to learn it. Chances are we'll all walk out of E&M here in basic coding, still a little iffy, still like, what? Sure, I know what's going on here. That's okay. That's okay. We'll get into it again in advanced. And sometimes once information kind of soaks in and you get more familiar with lingo and stuff, then it just kind of starts to gel and make sense better. So that is it for E&M. Hopefully you kind of know how to determine your level of service a little bit better. And we'll move on to anesthesia.